It's June 6, 2025. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. This week, we got a few new revelations, a few sort of basic rheumatology things, and I think some important numbers to remember. Let's begin with the numbers on vaccination. MMWR last week put out a report about their Vaccines in Children program, which began in 1994. That program basically allows all children to receive vaccines at no cost. Since 1994, this program has prevented over 508 million vaccination-related illnesses. It's prevented 32 million hospitalizations. And it's prevented 1.1 million deaths. The direct savings of this program has been $540 billion, and societal savings is over $700 billion. Again, these are numbers that come from the CDC. And if you think the CDC is biased, well, then maybe you won't believe these numbers. But I think these are important numbers to realize, especially as vaccines are falling under a lot of scrutiny. A nice basic piece comes from the Canadian Medical Journal, where they reported a case of parvovirus B19 presenting with arthritis. And while we may all teach that or have heard about that, I must say I really haven't seen much of that in my career. They go on to point out that the B19 virus is more likely to be associated with arthropathy than it is with the classic slap cheek rash. It's seen in up to adults who get this infection, up to 60% will get musculoskeletal complaints, mainly in the form of a symmetric polyarthralgia that can look a lot like RA. A subset of those will have inflammatory polyarthritis, mainly affecting PIPs and MCPs, other joints also, but those are the main ones. So it kind of looks like RA. The interesting thing about this is that it's a self-limiting condition in the vast majority of individuals with resolution of symptoms in 3 to 4 weeks. Maybe as much as 1 in 5 will go on to have symptoms and arthritis that can last months to years. Actually, now that I remember, I had one patient, and I was perplexed by this one patient because she had clearly serologically proven parvo B19, and I managed her for a while with non-steroidals and steroids, but she continued to have symptoms. And you know what? She stayed as RA. So did parvo B19 unmask what was going to be RA anyway, looking for a trigger? Or can parvo B19 in a very few people settle into RA? You can tell me next time you see me. A systematic review of JAK inhibitors and systemic sclerosis. We've covered this a few times at ACR and EULAR, and next week is EULAR. We'll be covering the meeting. Watch for what we're going to say and do. But in the past, we've talked about reports about JAK inhibitors being used in systemic sclerosis. In this meta-analysis of 18 articles, 87 patients, not a lot. So these are single case reports and a few small series. That age was highly varied. Most of the JAK inhibitor use was 80+% tofacitinib. And the JAK was either being used to manage either skin disease, progressive systemic sclerosis in the skin, with ILD, or progressive skin disease with GI manifestations, 45% and 39%. In this meta-analysis, and this could be a reporting bias, 87% improved and only 6% relapsed. A high amount of adverse events, but they were not all that serious. 20% had infections, although those were mostly minor. We do need controlled trials. I think it would be exciting to see if this really panned out in a large phase 2 trial. Report this week about Blau syndrome, a rare autoinflammatory disorder with a triad of granulomatous dermatitis, arthritis, and uveitis that, if unrecognized, can lead to blindness. This Blau syndrome I know about because it's one of the autoinflammatory syndromes resulting from a NOD2 gain of function mutation with a variant of NOD2 gene. These this condition mainly affects young children, 2 to 4 years. Treatments this meta-analysis was looking at the treatments. In fact, I looked at 2 different sort of studies, meta-analyses. One said that biologics work. The other one said that the biologics, especially TNF inhibitors, are probably good at controlling the joints. But one meta-analysis said, you know what, it doesn't seem to matter. There's no preferred therapy, and we need a better therapy, especially with regard to the uveitis. So that can be a real challenge. Another nice revelation this week is this report of 90 systemic sclerosis patients where they did a lot of testing, and they found that IL-40 is elevated in systemic sclerosis. So they compared 90 sclerodermas to 90 controls, healthy controls. They had skin biopsy in 5 patients versus healthy controls. And they found that IL-40 was significantly upregulated in the skin, and it correlated with disease activity measures for scleroderma, the ESSG. It also correlated with GI manifestations, also with IL-8, TGF, and TGF-beta. It is a cytokine that has been linked to a number of disorders, mainly because it seems to be pro-inflammatory. It comes from activated B cells and polys. But what I liked about this was it seemed to be pretty impressive. I'd like to see this studied in other cohorts of scleroderma patients. A nice case report this week, a reminder that isoretinoin can cause sacroiliitis. It is rare. In a review of 67 patients in the literature who had this rare complication, they were all young, 21 years, had a median onset of disease of 1 to 2 years, but with a median of 2.5 months after receiving or starting isoretinoin. The main manifestations were 70% with back pain, low back pain, and 45% with hip pain. Diagnosed by MRI, they often have bone marrow edema. They do not have erosions. They recover once you stop the isoretinoin. 80+% will recover. Seen a few of those in my day. So a registry study of 17,000 psoriasis patients looked at the drugs that they received and really asked the question, do the drugs that are used to treat psoriasis also treat psoriatic arthritis? I think you know the answer to that, but in the dermatology literature, I think this was JAMA Dermatology, they found that in this cohort of 17,000 PSO patients that 19% had PSA. So biologics were being used in 45% of psoriasis patients at baseline, more so if they also had psoriatic arthritis, 66%, right? It turns out that in the psoriasis patients, there was about 9% who were put on a drug that would work for both. The point is that because they're treated for psoriasis doesn't mean that drug, that biologic, is going to work for psoriatic arthritis. And that's something you should be teaching primary care and dermatology. Another look at GLP-1s. You're going to see lots of literature on this. A 5-year cohort study looked at obese type 2 diabetics treated either with semaglutide or with sitagliptin, which is Januvia. And they showed that the ones who are on, the diabetics who are obese that were on the semaglutide, the GLP-1 agonist, had a significantly lower risk of osteoporosis, 39% lower, and a significantly lower risk of gout, 37% lower, compared to being on sitagliptin. Interestingly, this study argues with the results of other small studies that says that it might benefit knee or hip osteoarthritis. This study did not show a lower incidence of knee or hip osteoarthritis. A retrospective VEXAS study of 59 patients looked at their treatments, and if you're treating VEXAS, you might struggle with what is the best therapy. These patients were 98% male, supposed to be mostly male, mean age 71 years, and nearly half of them had myelodysplasia in process. Treatments that they used were tocilizumab, anakinra, azacitidine, baricitinib, and prednisone in just a few. The best responses in this cohort was seen with azacitidine, which is, I think, a hematologic drug, and tocilizumab. Put that away in your cap. It may come in handy. A nice revelation again this week in calcium pyrophosphate deposition disease. We actually have, coming from a gene-wide association study, the cohort was the Million Veterans Program, which is a study of 550,000 veterans. In this study, they found that there were two genes that were positively linked to CPPD. RNF144B and ENPP1. ENPP1 they know something about. It's got something to do with phosphorylation. They really don't know what RF144B is, but again, the association here has been seen in Americans, which is calcium pyrophosphate, but those genes are specifically associated with those of European and African ancestry. Interesting, right? So, again, these same genes are found in our society, but also in those continents as well. So we're getting closer to a better understanding of calcium pyrophosphate disease and its clinical associations. We reported in the past that there's a rising incidence of autoimmune disease. I'm going to talk about autoimmune disease in the next three reports. First, a review of vitiligo, and that, as we know, is an immune-mediated disease that has significant psychosocial impact, quality of life impact. Patients with this are profoundly affected. A review of the therapies basically says, number one, the only FDA-approved therapy for vitiligo is ruxolitinib. It's a JAK1 inhibitor used for hematologic indications, but that other JAK inhibitors have been studied in several studies, mainly tofacitinib and baricitinib, showing the same benefits, and that's encouraging. I did not know that other drugs are out there that have been tested with positive results, but these are not FDA approved. Simvastatin, metformin, and afamelanotide. You can look at the citation if you're interested in the drug. I can't pronounce it. I'll bet that you can't either. Alopecia areata is in the news, and that the incidence of that has gone up in the last 30 years, between 1990 and 2021. In 1990, the worldwide incidence, looks like it was 20 million people, but that by 2021, 31 years later, it's now almost 31 million affected globally. The highest incidence is seen in the United States and Canada, North America, where the incidence is over 500 cases per 100,000. Other high prevalence countries would include South America, Southeast Asia, and Australia. Lowest incidence is seen in Africa and the Middle East. And another report of rising incidence of autoimmunity comes from the UK. It's a UK study showing that autoimmunity is being found at higher rates in women who are pregnant. So this is a UK CPRD. This is a well-known database that's mined for population-based associations. In their study of almost 21 years, they found 185,000 pregnancies in 100,000 women who had autoimmune disease. They looked for the prevalence of autoimmune disease amongst this cohort, compared it to those without autoimmune disease. And what they found is that in, what's the year here? In 2000, the incidence of autoimmune disease in pregnancy was 3.5%. By 2021, it's now up to 4.7%. They're specifically looking for 17 autoimmune diseases, a wide array, including many of the drug things that you see. But the thing that they saw most in association with pregnancy was psoriasis had the highest prevalence. If you consider psoriasis an autoimmune disease, and I do. The greatest increase during this time period from 2002 to 2021 was for Hashimoto's thyroiditis, followed by celiac disease, Graves' disease, and type 1 diabetes. To me, the big report this week that's kind of controversial is the report that showed up in JAMA on methotrexate failing in osteoarthritis. It's a report out of China with an accompanying editorial by Nancy Lane, basically saying, put the nail in the methotrexate osteoarthritis coffin. It doesn't work. It's not quite that simple. In this placebo-controlled randomized trial of 215 patients with knee OA, they enrolled patients with knee OA that was inflammatory, meaning they had to have effusions and or synovitis on MRI. And when they looked at the patients treated with placebo versus those with methotrexate, no significant difference as far as the 1-year outcomes. You might remember that last year, I think we reported a Annals of Internal Medicine article that said it does work in knee OA. And in this article, which is from MedPage Today that reviews this, it basically says if you look at the preponderance of data, there's reports about methotrexate in hand OA suggesting it might work. And in knee OA, it kind of depends on whether there's an inflammatory component or not, and it seems to always fail when there's inflammatory disease, or whether it's just degenerative OA, and occasionally it seems to work there. I studied this when I was at UT Southwestern, I think around 1993 to 1995. I think I enrolled about 24 patients in a double-blind randomized placebo-controlled trial. I was really jazzed by some of the results I was seeing, but I was blinded. After I unblinded it and looked at the data, there was no effect. We treated patients who only had DJD, no effusions, no warm joints, no positive MRIs. We didn't do MRIs. We had MRI data in a few, and they had to have normal sed rates and CRPs. Now, I recognize that osteoarthritis can cause some of its damage by intermittent bouts of inflammation. And maybe methotrexate, and that was a basis for our study. Our thinking was that methotrexate would knock out those intermittent bouts and prevent ongoing pain or ongoing damage, and we didn't see it in our very small cohort. I didn't report that, by the way, because our cohort was so small. I thought I was going to have a hard time with that, and I thought, who other than me is crazy enough to do a trial like this? Well, many people have done it since then, and I think that right now it's equivocal, and that's sort of a negative answer as to whether methotrexate works in knee OA. That's it for this week. Be sure to tune in next week for more information. We're going to be coming to you from EULAR in Barcelona. Be there, follow us. We're going to have fun. We hope you enjoy it too. Specifically, what we're going to do is EULAR starts on Wednesday the 11th. Starting on Thursday, Friday, and Saturday, we're going to do a live day 1, 2 report, day 3 report, day 4 report with a panel at 6 p.m. Barcelona time. I think that's 12 noon Eastern time here. And you can see those videos where we're going to discuss what's happening at the meeting. You can follow us on Twitter. And then when we get back from Barcelona, we're going to have panel reports on RA, PSA, SPA, etc. Hope you enjoy our coverage. We'll talk next week.